All right. So, warm welcome to another lecture on biomedical microsystems. And today, it should be, here we go, on neural implants to restore vision. This is a kind of an historic lecture, I have to say, since I want to give you an overview on the different fields that came in, and I slightly updated some slides yesterday, and was too tired to put them on the Ilya system. So there are some slides missing, to be honest, since this is a quite sad story. People did research over 30 years, and this is one of the rare cases where the technological developments brought science to the point to find out that the basic understanding is not good enough on the whole field, and so they stopped clinical research and went back with their questions back to the fundamental research on the lab bench to develop physiological processes in a different way, pose questions in a different way to better understand the fundamentals. Therefore historical, since this was this year in spring, that one of the companies decided we too have to close because we don't understand what our implants are doing. And this is something I like to comment on. I left out some recent developments here on a special purpose, and this purpose is that this lecture is not only vision implants as a very exciting application of biomedical microsystems, but this is also about how to package flexible foils and electronics. So last time was more on silicon, so the whole probes for the brain were how to integrate stiff things together, that it's good for something. Today it's about how to integrate flexible things on polymers with electronic circuits. That is, let's say, the technical background. Apart from that, a good application is vision prosthesis. Latest developments use conjugated polymers, electroactive polymers, in a way that you create stacks of different conductive plastics, to say it in very simple words. In a way, if light shines on, they generate charge carriers, and these charge carriers stimulate. That's a really cool approach, so you have something like organic photovoltaic panels in the eye. This is really cutting-edge research, mainly done by Daniel Palanca at Stanford and Diego Getzi at EPFL. But this is so far off from all the other approaches on vision prosthesis from the material science point of view that I thought I do not want to confuse you completely. So I'm well aware of those things, but just for, let's say, more introduction, educational reasons, I cut them out. So it's more on the other things here. So, saying that, this is here about these polymer systems and the hybrid assembly. Let's start with a physiological background of the human eye. That's very important. If you look at insects or flies or whatever, they have different concepts, beautiful concepts, but since this is here on tools to interface with the human as such, I don't comment on the fly eye or on the bee eye or whatever, but on the human eye, which is comparable in many mammals. So it's similar to mice and rat and whatever we have, but some details are different in rabbits or in dogs, for example. So the human eye, we have the eyeball, we have the light coming in through the lens. the lens has optical properties to focus the pictures on the retina, and if I look around, enough persons wear glasses here, so you know what happens when the optical system does not work that well. Then we have a blurry picture, we cannot see what's written there either in close distance or in long distance, so we correct the optical properties with a pair of glasses. In the background we have the retina, which is in electrical engineering words a kind of transducer between light information and electrical signals. A lot of cells, and they go over the optic nerve to the brain. If we look on the human retina, we have a special situation that the light has to pass several layers of cells before it comes to the sensors, the rods and cones. And we have the chemistry behind that. That's come later to that. So we have the rods and cones here, and they have signal processing units in the other cells, like the horizontal cells, bipolar amacrine cells, which give those on and off things. That means we see contrast already on the retinal layer, and they give movement information. That is something you well know. If something happens in the outer periphery of your visual field, you tend to turn your head and focus on that. That's for me extremely boring, annoying, sitting in a sports bar when I want to talk to somebody and a lot of screens are everywhere, and I always have to look there just for evolutionary reasons, because that bothers me that there are moving pictures all around. And these cells are here to use those transducer level and to converge that on the ganglion cells with a bit of signal processing, as I said, and those ganglion cells here go into the optic nerve. They build the optic nerve, the axons of the ganglion cells. This goes to higher levels. And these higher levels are shown here. The optic nerves go over the optic chiasm, then to the lateral geniculate nuclei. Other structures here we can omit a little bit, and then it comes to the primary visual cortex, where we have that perception on, let's say, the cortical brain level. While we have the visual fields left and right, so just where you look in the eye, this is split up here, that both left visual fields from the right eye go to the left side and the other way around. So we have from the optic chiasm on, left and right hemisphere separated in the eyes. That's important to know if you suffer from a brain stroke, for example. Could be that you lose a part of your visual field in both eyes, because that part of the brain is considered. So that's different. If you lose something in your eye, then the other eye could compensate that. If it's in the brain, you lack a complete part of your vision in space. And when we talk about vision prosthesis, we like to restore lost vision. And the question is, how do people lose vision? And the trauma or the disease behind that is very important to know to get the right treatment or the right rehabilitation. There are a lot of, let's say, diseases or events that cause blindness that are easy to treat. A lot of children got blind and get blind during birth, since there are some bacteria in the birth canal that cause blindness by damaging the cornea. And the treatment there would be to give a droplet of silver chloride after birth in the eye. It's something of sense, and that can prevent things, or having kind of treatment of the mom before giving birth. There is the cataract, so your lens gets opaque and light does not get through, and then you either can remove that or replace that opaque lens to get vision back. That's something what we are now not talking about. Here we're talking about diseases where you lose the transducer components, so the rods and cones. And you can imagine looking here, if you lose something in the eye, you have the option to interface in the eye or on the optic nerve or in the visual cortex. However, if you would have a tumor here on the LGN, it doesn't help to place something in the eye because the signal transmission then between the eye and the brain would be disrupted. That always means we have to understand the disease such that we address beneficial interfacial points on the nervous system, and we blank out those which are no longer useful. This is nothing that an engineer does alone. You always need, of course, that interference with a good guy from ophthalmology or neurosurgery or whatever. All those developments for retinal vision prosthesis, but also for the other vision prosthesis, have been triggered by a disease that is called retinitis pigmentosa, which is an hereditary progressive retinal degeneration. So this one is a gene defect that somehow plays a role in the generation of rhodopsin, so that chemistry in the background which adapts our vision to different brightness levels. And this causes shifts then in the homeostasis of the eye where a lot of cells die, and it starts from the rods and cones, so you lose the transducer elements, or we lose the transducer elements first, and also the other cells die. The good thing is that not all cells die, but ganglion cells, so the layer that is the one closest to the eyeball inner side, and creates the axons to the optic nerve, they're still there. This is a healthy eye on the left-hand side, seen through a magnifying glass lens that is placed directly on the eyeball, and you can look through. While on the right-hand side, there's a pattern coming from the periphery of black, grayish structures, plaques. That's the place where it starts and the retina degenerates. It can start already in the early 30s, and then it has a different progression rate, and you slowly get blind by that. And the disease produces something that is called tunnel vision. So you lose your periphery. You still have precision vision in the macular region, so the point of highest acuity, but you lose the periphery. And if you want to experience how that is, take a whatever piece of paper, make a roll, and just look through. And that means you see a point, but you cannot see the scene. And it's really hard to navigate. And if you have if you're under a certain acuity, you're called legally blind. And if you're legally blind, you have there are certain legal rules, different in every country, but you get, for example, free bus tickets, or you get a retirement pension for getting legally blind. I'm telling that because that has been a psychological issue of some persons when being in inclusion criteria, of for clinical human studies for vision implants, and I said, hey, I don't want to have that. Can now ride the bus for free. If I get that prosthesis, does that mean that I have to pay the bus again? So do I lose some financial benefits without knowing if this rehabilitation device really helps me just by being included in that study? And this is something one has to know, because otherwise, are they crazy? They get something for free and they complain?
Yeah, but that's a true issue, because for example, if they cannot drive because they have retinitis pigmentosa and our prosthesis does not fix it, they can literally not go to places.
Yeah, right. But I mean, it's important to know from the psychological thing, if you talk to persons or try to get them in to consider those things. And it's important to really assess the degree of blindness to be able to evaluate the performance of such a rehabilitation device. Because if people come, they say, I'm blind, and I was on a scientific advisory board in Australia, on Bionic Vision Australia, who also developed the vision prosthesis, and they had really scary things. Said, this is here the 10 pages contract that will give you with you at home. And then after half an hour, one came back and said, hey, I've read I should sign this and this and that. And, sorry, didn't you say you're blind? Yeah, but I have a little bit residual vision. I mean, that's good for the person, but I tell that story because you have to see the difference there between legally blind and completely blind. This is important to know, because if you have still some residual vision, little bit of light and dark, this helps you to trigger your circadian rhythm, for example. While if you have nothing that could trigger that rhythm, and so a lot of persons being blind have difficulties in sleep and awake rhythms, for example. And that's important to know in advance when it comes to those points that are sometimes clear for certain experts in that field, but are not that clear for all the rest who's doing, let's say, the stuff around. Right? And this is how it looks like. In parallel to that, a lot of persons above the age of 70 suffer from age-related macular degeneration. Means you lose the focal point of acuity vision. That means you still see the scene, but you can no longer read, for example. There are more therapies now on the pharmacological base who treat age-related macular degeneration. That means this is no longer inside the storyline of vision prosthesis development. So people always said, we have to develop 2 points, one for retinitis pigmentosa. There are not so many persons, but we understand the technology, and then we scale up the technology for higher acuity for persons suffering from age-related macular degeneration. I was also one of those persons in my postdoc period who spread the news according to that. I'm no longer sure if this is a good storyline, since age-related macular degeneration has now a lot of options in treatment, while retinitis pigmentosa still has none. One great hope is optogenetics for retinitis pigmentosa, that you do genetic transfection of the remaining cells, and the ambient light then excite those cells, give action potentials that are then passed through the remaining network to the brain. I do not like to comment on that, since I'm not an expert in that. So it's probably a good option, but we all have to see how first clinical trials run with that. So if we come from the engineering side and say, okay, dear colleagues, we're happy if you find optogenetic technologies, but in the meantime, we're still developing technical aids to support persons at least somehow. We have different sites for interfaces. One is the retina, so directly in the eye. One could be the optic nerve, and the third one could be the visual cortex. And there are many good reasons to interface one thing or the other. So, and you always find reasons why you don't want to interface that part and not the other. For example, the eye is very small. So if you talk to persons who prefer the visual cortex, they would say, oh, it's beautiful, you have so much space here, you can place so many things in there, it's under the skull. So we have mechanical protections on top with the skull, we know how to implant things there, beautiful. Somebody else would probably say, who's not that much in favor of that, but comes from ophthalmology, why should I drill holes in the skull when I can interface the eye directly? Yeah, and if I can take something that directly interfaces light into electrical voltage, I can use all the remaining computational levels here of the whole visual system. And you find hundreds of reasons for one thing or the other. Therefore, I like to walk you through and start with all the other options. Because people, quite often, if you talk about vision prosthesis, still people say, yeah, but I know there's an array of vibration for your back, and this is much easier and you don't have to implant that. That's right. There are such arrays that project via camera to an array of vibrators, the picture on your backside. But you have to know that your 2-point discrimination of your back is about, depends on you, between, I guess, 8 and 12 centimeters. That means I'm not that gym type, so my back is not that large. That means I could probably have 4 contacts, probably 5, times 5. That's not that much for images, right? And you can have 60 by 60, but you cannot resolve them just by the innervation of your back. And normally you don't, if you want to touch something or get detailed information, you don't rub the back somewhere, you take the fingers and go over it, right? And that's the reason why, for example, braille reading, those MOPs, which code letters for the blind, and reading are that small, because your tactile resolution of the fingers is much better. You can have auditory representation. So you have a camera and a voice decoder, and the camera tells you what you see. This is on one hand very good. On the other hand, it's probably a bit annoying if you're in a conversation with a person and you have an earbud that talks all the time, telling you what is happening in the background. Yeah, so it's probably good for some persons who love that, and others will hate it. And this is always what you have to consider there, if it's good or not. We have dogs that are educated. You have sticks that you can use. So many things around. I've read a nice book on that. So on a person who gets the diagnosis that he has retinitis pigmentosa, written as a novel. It's called Blind Fish. So forgot about the author, to be honest. I know how the cover looks like. It's black and white, and the title is Blind Fish. And this is a person in the US reporting how that feels, and how he's then engaged into programs to get along with a dog, with a stick, what he should do, and stuff like that. So let's browse through the different approaches. And since I've worked on retinal vision prosthesis for about 10-15 years, my focus is on that, because I know most about that, and it's a good example to show you which challenges you get with integration of devices. All the other things have similar challenges, so you can easily transfer things from one to the other, but I did not want to spread it that much in the other. The cortical vision prostheses are amongst the old ones. This is a picture from the 1980s. The oldest visual cortical prosthesis to restore vision was investigated by Giles Brindley, a British neurologist, in 1967-68. He implanted a blind nurse. Now I have to remember. I guess it was 32 coil transducers, so inductive transducers, coil and 2 wires on the surface of the brain. And then this lady got a cap with 32 coils outside, and then they switched on one coil or the other, and she reported flickering fireworks. That means she had some perceptions that did not help much, and today one would say this caused a shitstorm. So Brindley was originally elected to set up the most famous British Neurorehabilitation Institute, and after these human clinical trials and his publication, they decided differently, and 2 years later he came back with a bladder prosthesis. So he never worked on vision prosthesis again because he was banned on that topic. That was much too early. The good thing one could draw out of that is he proved that cortical vision prosthesis can work on principle. The second guy was Dobell. The Dobell Institute in the US is still present, and this is that was one of the real persons. There was a kind of animation. There was an array of electrodes placed over the visual cortex with more than 60 contacts, and in those days and still today there is no connector for 60 contacts available worldwide, and there is no package which has a connector to connect them. That means they had a finger-thick cable sticking out of the skull for those patients, and that worked up into the 2000s, that approach. People have seen something. Some people were driving cars on a restricted ground, not in general traffic, but on a restricted ground with a journalist sitting next to them. The journalist was not that happy afterwards. And there are reports on that. And the outcome was that this particular array they used with that particular approach was able to restore some kind of vision, but the currents were such high that permanent use of that vision prosthesis caused epileptic seizures. So not the best, you know. And of course, that percutaneous wire is something that might cause infections. So they stopped that, and this is one of the early cases where technological decisions were not well communicated to patients. So those patients, even though they suffered from epileptic seizures, they had not perfect vision, they had an improvement of life by getting one of their senses back. And if you have a spinal cord injury, you lose hearing, you lose sight, you get severe psychological issues undergoing such a situation, and you have to cope with that and get along on the long-term run. So if you get a rehab device that restores something, you rely on that. And if this is just switched off from one day to the other, you undergo that trauma and those psychological issues for a second time. And there was no care taken for those patients. They were just left on their own. And this is one of those cases where we should think from now, from the 21st century on, backwards, that we probably should consider those things early on and take measures that those persons get at least decent mentoring, supervision, kind of something that they're in good hands. Newer cortical vision prostheses use small needles. Might it either be a very sharp and thin wire that is connected in small ensembles of 8 or 16 together with a wireless system, or something like a silicon-based array where needles are poked into the visual cortex to get a lot of contact sites and restore vision there. This is an ongoing research from the early 90s up to now. There are some groups working there. Phil Troik from the Illinois Institute of Technology is still working on that. And rumors say that he's close to a human clinical trial. Eduardo Fernandez from University of Alicante is working on a telemetric system on a European level, and there's another project now currently going on with contribution here from Freiburg on that. But as you see, over 30 years, it's still a long-lasting issue on long-term stability, on resolution, and on usability there. We had, and that was a huge thing, around 2000, 2010, in that time frame, also vision prostheses using cuff electrodes, with the idea to have an insulator with contacts on the inner side, and you wrap that around the optic nerve and stimulate the optic nerve. You have to know that the optic nerve has about 1.2 million fibers coming from 1.2 million ganglion cells. That's 10 to the 6th. We have 10 to the 8th rods and cones in the retina that then converge to just 1 million fibers. And this cuff electrode, one cuff electrode, the first one had 4 contacts approaching 1.2 million fibers, and the second one had 8 contacts approaching 1.2 million fibers. And you can imagine that this is a difficult relation for good selectivity. And they stimulated, and persons saw, depending on the intensity of the stimulation and the local site, different shapes. And they now tried to do that stimulation such that you can generate kind of flashlights of objects. So imagine we take that paper roll, or imagine a bottle that is standing here, and you want to see that. So you have a camera, and you do an over contrast image that you just see the perimeter of the objects. Or a black and white. Yeah, the bottle is white, the rest is black. But you have only one light spot. And that would mean, if you want to, you might know that from lousy B science fiction movies, from aliens from outer space. If they shake their robot head for vision, you just have a camera and you scan objects. And whenever you see an edge, that gives a light spot. And this is how that kind of vision worked. And that means they have a checkerboard, 3x3, and persons had to identify, is there a coffee mug, is there a plate, or is there a banana? And so they scanned, edges gave contrast, flashlights, and then you had to assemble the picture in your mind by remembering where the flashlights have been. That took between 60 and 120 seconds. And this is something which is not helpful if you want to navigate in traffic. If it takes you 120 seconds to see if a car is coming, the car is either gone or just approach you when you're in the middle of the street. Right? So this was good for fundamental research, but not that good for daily use. The operational procedure. The surgery was a bit odd. And the first patient was done over the base of the skull. So you had to open the skull base and then approach the optical nerve from below. And in the second patient, they just took off, and that sounds really scary, they just took off the eyeball, wrapped the cuff around, and put the eyeball back. So there was a surgical procedure in both, where I felt that's rather from a scary movie than from a scientific report. But the good thing was that a lot of knowledge has been acquired there. But at the end came out that that is well, I wouldn't say a stupid approach, but not a good one to interface that. And the idea was then to go into retinal vision prosthesis with the idea to implant things in the eye with an energy supply somewhere and a data link that is good enough to transfer telematic data. And the boundary condition was the system must be such that the ophthalmologist is still capable of monitoring the background of the eye. So no way to block the complete eye in front of that. There's a few who are Trekkies and have monitored the latest, well, all the series where Geordie LaForge is in, will remember that he had first something strange over his eyes, and in later parts he had something that was implanted inside the eye. And the funny thing is that this second version of Geordie LaForge is similar to all the approaches that the researchers have been done. And I don't know if the researchers copied the TV series or the TV series copied the researchers. That is a thing probably not for us as engineers, but something more for persons from literature, because there are similar things if you look on submarines and rockets and early Jules Verne textbooks, that later rockets exactly looked like the pictures of those early books. And this is probably a kind of interdependency that I find quite interesting to see who influences whom in such a development. So, but let's jump back to those approaches, and this is one of the early pictures that made it on a lot of web pages and somewhere else, and caused a lot of discussions. The idea was in Germany to fund two competing approaches, and that was the time where those two approaches have been researched competitive all over the world. And then there was a little silence. That was about 1995. There was a little bit silence, and now a lot of stuff is not repeated but done on a different level with organic electronics. Yeah. And therefore I think it's quite good to start with the early stuff to understand a little bit the approaches, and then it's easier for you to transfer the approaches to current technologies, better than come to current technologies and do not understand certain choices why people did it. And the idea was twofold. It could be either that you place an implant in that area where the rods and cones have been. So that means you replace those light sensors by technical light sensors. And if the light comes in, still use the optical system of the natural eye. Have a kind of photovoltaic cell here to stimulate, you generate an electrical potential, and that electrical potential excites the cells. That's one option. Criticism was, you cannot put a technical system in that delicate piece of the eye that will destroy everything. Yeah? That's always a good argument, because you cannot prove that until you have done that. Okay, that was one argument. The other was, and the beauty is, of course, you don't need a camera system. You need the optical system of the eye and everything's fine. The alternative, where people said, we don't want to stick something under the eye, that's under the retina, that's too dangerous. Let's put it there where the ganglion cells are, because we know that they are remaining. So we take a camera system, we'll do a lot of computation, transmit then the pulse train information and try to stimulate the ganglion cells directly. There has been also an approach where people said we use that epiretinal concept and place it underneath the retina or place it somewhere a little bit more in the background. This is something which I know that people did that, but for simplicity reasons I like to leave that out here when presenting those things. So in the subretinal space there were several groups worldwide. The early ones with photovoltaic cells did the first study in the US, Optobionics, the Chow brothers. Unfortunately came out that they were a bit over-optimistic in interpretation of their first results, to be very politically correct. Less politically correct persons have said they cheated. So that means after their first trial they were off, because results were not in accordance somehow with the data. So persons had better sight on places where the implant has not been. That was a bit weird. Years after that came a good explanation. If you manipulate the retina, it might cause better cardiovascular function somewhere else, and that might increase vision on that spot. But that means it was not the implant, it was the surgical procedure that caused improvement in sight. Joe Rizzo and John White did that at MIT in Cambridge, and they changed horses and decided later on they go to epiretinal because their system would stimulate much better changing the sides of the retina. There was a huge group in Tübingen, and they made it up to a product. And I want to share some things with you there. So what I already said, this was the famous picture from the Chow brothers. They implanted a photovoltaic cell over there, and I think they got better vision next to that. The colleagues in Reutling, mainly Wilfried Nisch and Martin Sterzler in those days, they developed photovoltaic cells. We have here that photovoltaic cell, PN junction. If light comes in, it separates charge carriers. You have the back side of the structure, the counter electrode. That means, and this is the electrode here, that means you generate an electrical field between that electrode, one of those dots, and the back side of that structure. And by that, the idea was to stimulate the retina. To be honest, they stole that design from Optobionics, so the first one. They just copied that one-to-one and tried that out. So you see 7,000 photodiodes with 20 microns diameter. That's a cool resolution there. However, it came out, photovoltaic cell, silicon, that's around 0.7 volt. That was not enough. That was not enough to stimulate. You have fluid in, cells grow in, and 0.7 volt is not sufficient. What did they do? They put several elements in a row, and if you put those elements in a row, you add on the voltage. If you put 4 elements in a row, you get up to 2.8 volts. Downside is the resolution gets lower since you need more area with that. So they went a little bit larger and it looked quite well. And after a lot of years, they transferred that from experiments on the lab bench in a beaker with salt water, with phosphate buffered saline, even at elevated temperatures, in the first animals. And they found out, and this is always the scanning electron micrograph in the lower row and an interference optical microscopy image on the upper row, on the left 3 sides. And if you see those rainbow colors, that's always a good sign if you have interferometry and the colors are different, that the thickness of the layer might vary. It's like a droplet of oil on water when the sun shines in. And that meant that the body and the foreign body reaction tended to eat up the insulation layer of that structure. That went up to here a micron of eating up the insulation layer after 18 months. And then they had to stop and redesign that stuff. And the reason that it degraded was that they used the standard process for microchip manufacturing. And the oxide that is used there is good for microelectronics in dry environments. But it has a lot of point defects, and if you put that in salt water and cells come, they eat up that silicon dioxide. And they had to change the complete process from the so-called TEOS oxide, that's a low temperature tetraethyl orthosilicate dioxide, into something that was more dense, less point defects, and survived. I was a young postdoc in those days, and then we were sitting in a meeting. We were in the competing consortium, so of course we read all their papers and all their stuff they did. And then a guy came and said, I know, I found a paper where they have the solution. And this is a warning for you. This is one of the iconic papers here, Hämmerle Biomaterials 2002, to show how important in vivo experiments are. And then came a guy and said, I found that paper. And there was a high-ranking journal who published something and said, you should take silicon nitrate. What? You know, we normally use silicon dioxide and silicon nitrite, so Si3N4. And there was written down they use silicon nitrate with A. And then I checked it up, and normally farmers put that on their soil, that roots grow better. And I have no idea where this typo came from. It was just a typo. Or it was something, you know, that a guy from Texas with a broad accent had a telephone call with the East Coast guy, and they did not understand correctly what they were talking about. That this was one of the famous typos. They used, of course, silicon nitride, and not nitrate. But this was a typo in there that bothered all the engineers and physicists in the field for about 10 years, because every 2 years another ophthalmologist came up with that paper and said, here's in that, it's so stable. Yeah, sorry guys, it's a typo here. And therefore, I like you to be very careful if you read things. Same between nitrate and nitrite, even worse, is the translation of silicon and silicone in English and in German. Silicium, silicon. Silicon is the piece where chips are made on, and silicone, polydimethyl siloxane, is the rubber thing. And quite often people don't take care when translating it, and I've seen many papers about new silicone chips. And I say, oh, beautiful, they made now semiconductors out of rubber that I have in my bathtub. No, it's just a translational error. And therefore, I kindly ask you, be very careful, always think twice if you read something like that, if you write something like that, and you know that there are those options of typos, please take extremely care on those words. That's because if it's once spread out in a general newspapers, it goes viral. And then you have wrong expectations, you have wrong information spreading around. I think as scientists we are responsible for that, to checking that twice, even if we are not the masters of making press releases. It's good to have those open eyes there, checking it carefully. So, here comes now the subretinal vision prosthesis approach, and of course the beautiful idea was not as easy as thought. So at the very end they found out that doesn't work completely on its own with that photovoltaic array. when you are not in the Sahara Desert but in any other environment, the light density is not good enough to excite enough to generate enough voltage to stimulate the underlying cells. What they did was to use that photovoltaic array that takes benefit of the human optical system as a kind of modulation matrix. So they had the power pump underneath for the amplitude, and they used the light information as switch to let that power pass through. And this is shown here. So there was an infrared receiver for powering the whole stuff. And later on, this was done even with a telemetric unit behind the ear in a package that you have had some electronics and some telemetry for powering the system and a conventional implant package, while having then a cable to the eye and the photovoltaic array as detector to transfer the excitation to the retina. And this strip was implanted underneath the retina. And later on, all that stuff with cable and package came on top of that. And there were, at the very end, probably 2-3 groups worldwide working on that approach. Epiretinal had more groups working on that, and I don't know for what reason. Probably for the reason that people could better imagine to having a camera to take that picture, to extract features, to make stimulation trains out of that and transfer that into the eye. There were places all over the world. A company in Japan who jumped in there, Bionic Vision Australia, put a lot of money in there. Alfred E. Mann Foundation, it's a philanthropic research institute, founded out the company, and they got even FDA approval and CE mark. There was a German company, which then later on went to France, and another German company. And I have that at the very end again. So the idea here, picture CMOS camera in glasses, and that was real new. There were no smartphones in 1995. So all that camera chips that we have now smartphones, have not yet been invented there. But the idea was really to use something like that, have a handheld encoder, transmission, and transmit everything to the eye. It was really a huge discussion because that guy who developed the ideas of that signal algorithms needed workstations that filled half of the room. And that was the main criticism of others, saying, hey, you cannot take a truck with you with all those signal processing workstations there. And I said, I believe if the project is over and you have done your implant stuff, we have it handheld. And we always thought, hey, come on, that's not a good idea. That's not a good answer. That will never fly. And at the end, it really turned off. He was right. So after 10 years of the project, all that computing power was on one PCB that could be really handheld. That was amazing how fast that all developed. So this is really doable. You can put all those high-end computing on small things. The idea is, and this has been really new and is still one of the main challenges in all of those implants, no matter if it's a vision implant or another implant, is the question of signal information encoding. So if light comes in our eye, we have the rods and cones, they have a transfer function. And this goes to the bipolar cells, and they have a transfer function, and they have interconnections, they have synapses. Horizontal cells, they have synapses, they have transfer functions, and there's another transfer function to the ganglion cells. And the question is, can we identify all of those transfer functions, and can we do stimulation such that it mimics those transfer functions? right? Take the retina as black box, look what comes in, look what comes out, and try to find the spatio-temporal transfer function depending on the brightness, on the movement, on whatever. This has been really revolutionary to those days, and if you look in most of today's active implants, we still have fixed frequency stimulation at 60 or 70 hertz, and if they are really sophisticated, we have amplitude modulation, period. And that is, of course, not ideal. That has been also proven in other applications that the brain identifies at a certain time that this does not look physiological and doesn't like it at all. So one option that comes in the future or needs to be addressed in the future is really that encoding of information as close as possible to the original physiological data. That was the idea here, and of course we started with fixed frequency, because we did not know how this could look like, but they worked on an encoding there. The second challenge was the size of the human eye. It's really small. And if you put something in, the technical system must be lightweighted. Otherwise, it might drop down or drop out or cause whatever trouble. You need energy supply. You cannot implant a huge battery. That doesn't work. So where to place that? So you need wireless data transmission energy supply. And wireless means the smaller the coil, the more difficult it is to transmit. And the smaller the coil, the closer you should be, right? But you cannot glue another coil on the surface of the cornea. So that was also a challenge. Next thing is people like to move their eyes. Even blind persons, they do no longer have their saccadic eye movements, but they somehow move their eyes. So you cannot have a fixed coil and then you move your eye. You have no coupling there. Yeah, still some challenges there. And of course, how to make it stable in the human body. Is it biocompatible, what we're using, and how long will it last? That were all questions there. The easiest thing was to sketch how it should look like. Yeah, that was take a pair of goggles, put in a camera here, a coil, let's transmit energy and data inside the eye. We place everything we need into an artificial intraocular lens, because that cataract surgery is state of the art. And then we take just a tiny little cable to the back part of the eye, where we place a high acuity stimulator. I think that was done in a day. The rest took about 10 years. To those days, polymers beyond silicone rubber were not that famous, and my boss told me you should take polyimic. I had no idea why to those days. Now I'm a great fan of that. And one of the things is that the volume resistivity is relatively high and the dielectric strength. But all the rest was really an adventure to get that. There are now discussions that this is still too stiff. We should take more flexible material. We should combine it with hydrogels, for example, that we really have a water-like interface to the tissue, which is all true. But I strongly believe that we need something where we can integrate all the electronics. And for that reason, we use the sandwich approach to sandwich interconnect lines and contact pads in between two layers of an insulating polymer material. Use lithography, photolithography in the clean room to make the structures as small as possible and to integrate everything. And the first lesson I had to learn is that it's not just about making a design. It's making a design that is able to adhere to ball-shaped eye. And if you have something that is large and should cover a large area, and is stiff, it will never go to that ball shape. And you have to make design studies how to do that. And we had funny ideas about spirals, and if you have a very tiny little spiral and you lift it up, you cannot handle it at all. It might be flexible, but you will never bring it into the eye. We have had other structures that look beautiful, but were too stiff. And at the end, we came up here with some ring-like structures with spring-like interconnects that then by adhesion forces adhere to certain areas of the eye, and it was, let's say, good enough. But that was a good lecture for me and for many others to see how important it is to develop structures that are feasible to be implanted and are good enough to stick to the target tissue. And the second thing we did not learn in those days was you should definitely co-develop implantation tools. If you want to transfer, if your goal is to transfer something into a chronic application, you need tooling for the surgeries, and the surgeons, that things get implanted in a way that it's close to the standard implantation they know, in a way that you don't destroy your technical system. If you use new materials, you have to check up toxicity. There's that international standard that I guess I already mentioned once, that you should try out. That means you start with cell cultures, put cells on your new substrate, and if they survive, well, if they die, you did something wrong. If they survive, it just means that this material is in an acute phase, not toxic. That's the first step, but you need many more investigations on that. For example, if you cause allergenic reactions, if there are chronic things, if you cause mutations, if you cause cancer, all that stuff have to be checked out stepwise. And that was just the base material. And this is also something which took me some years to learn about, that it's not only about the base material, it's about all components. It's about the manufacturing. It's about the handling. So there are a lot of more aspects. This is just the basic step. And then we have the basic structure, and the question was, does that basic structure harm the eye without stimulation? Does it harm the retina? Does it harm the anterior part of the chamber? And this was here one of those early designs that was placed in an artificial intraocular lens in the anterior part of the eye, a bit like Jordi LaForge 1.0 version of Invisor. And this was here one of the first arrays that was placed in the back part of the eye, and this is an original picture how the ophthalmologist sees that through his surgical microscope. That means the acuity and the resolution is not that good. And then we came to the point where I got really scared when it came to how to fix that on the back part of the eye. The best thing, you would just put it there and sticks there, but it doesn't. So you need to fix it somehow. And the surgeon said, oh, we do it like always. Okay, well, what is always? Oh, we take retinal tacks. What is that? And, it looks like a harpoon, and we can just push it through. Okay, and this is one of those retinal tacks. It's really like a small harpoon, and you have an implantation tool where you can fix it on one part, and then you push it in through the retina, through the sclera, and it holds everything together. That's sometimes used if you have certain trauma in the eye to keep things together. It was really hard to convince the persons who did that not to place their harpoons through the middle of your technical device. This is something you have to learn. You have to make flaps with really obvious things to tell them, hey, this is the point where you should go through, and not through all the other parts. And this is good if it comes with associated surgical tools. They can say, this is the only special tool just made for you to use that. That could be just a pink pair of tweezers instead of a pair of gold tweezers, whatever, and having a tube over the sharp edges or something like that. But it's important that a tool comes with your device. What about assembly? Many of you might have heard about anisotropic conductive glues. That's so easy. You just take a toothpick and a little bit of that thing, put it on top of the contact, place your resistor, your capacitor, and it's fine. Electrical conduction is established. But does that hold when being bent, when being implanted, when water comes in? Those questions were something we had to address. Then the question, can we use soldering with lead in there? Now we have a lot of solders without lead, but other nasty stuff in, and does the temperature work during that? And it turned out that we then went to other assembling technologies, just to show you some lists here, and other persons come to other decisions. So there are currently many very sophisticated assembling technologies around that have been used. Funny thing is, we did something for completely different applications, and this has become one of the standard assembling technologies in academia for neural implants. And that was the idea. We had no clue how to fix those things. And we thought, why not taking something like a micro rivet? So if you have some substrate and you have your thin foil, why not making a hole in the pad of the foil? And then you can look through the hole and see, oh, my pad is underneath. So you have visual alignment. And then you take a bond machine, make a ball, put it on, and then it takes force and temperature and a little bit of vibration. And then you rip off the wire. And this is like a micro rivet. This is how old bridges and buildings have been done in the 19th century. The size is a little bit smaller here. We have wire diameters around 17.5 microns. And that means the ball is probably 30 microns in diameter. And with that, we had then a mechanical interconnection that gives you electrical contact. And this is very stable. We used the military standard from the US to check it out, where you have to shake that for hours. You have to drip it in liquid nitrogen and then boiling water for 2,000 times or something like that. And if it's still stable afterwards, it's good enough. We were very enthusiastic about that. It took me about 20 years to find out that there are some drawbacks. And one of the drawbacks is to make an underfill that those two neighboring contacts don't get a short circuit if you implant it for a year or 2 or 3. So it's feasible, but a lot of things have to be established. The funny thing was, we published that and a lot of persons copied us immediately and proved our design rules, which were just a suggestion for us, and others already thought this is standard operating procedure here. You can use it on the fly. And it worked out, so that was a good one. This is here an example how hybrid assembly can look like for such a vision implant. We have the electrode array here on the right-hand side. We have the transmission parts for the eye on the left-hand side. There was a chip for signal decoding, but we need energy. And what do you need for energy? You need a coil to receive inductive coupling. You need a capacitor to store that. And we needed a diode here for rectification. So if you have a sinusoidal wave, take a diode and you have rectified that, load the capacitor, and you can charge it to a point where you have DC voltage. And with that DC voltage, you can drive an electronic chip to decode data and transmit those data to a second chip that generates then the stimulation pulses being transmitted to the electrode sites. That was the idea. There are a lot of questions that one should ask, which I don't want to discuss with you today because they are much beyond an introduction here. Questions about what about DC voltages in a polymer-based non-hermetic package? Do we need decoupling capacitors to be safe? Things like that. So it's much more, but it's probably good enough as an introduction here into that field. What you can see is that diodes and capacitors are horribly large. And this has been improved over the years, so things can now be better integrated. They're smaller, they have higher energy density with that, and chips can be made smaller and thinner, but the foil design in many cases is still the same. Techniques have been established in the meantime that you can integrate those chips in a foil, that you really have flexible, bendable systems with electronics components. One issue in medical device manufacturing is the serial number, and the question, how do I get a serial number on such a thing? Because every device needs a single identifiable serial number on a wafer batch, and you don't want to change your mask for every run that you do. And we had some tricks, we had some ideas like gluing numbers on that. A lot of things were really stupid. We could have done them in a better way, but if you start with something, you have some ideas and you're really proud of that, and later on you identify that you should have looked somewhere else. Here is our assembling technology, and we had additional holes for underfiller where we can take glue that electrically insulates adjacent contacts. The assembly was done in the first generation by hand. That was a nightmare, and I was really happy that I had a technician who loved that. He was sitting there day and night doing that stuff by his hands, and I was pretty impressed how that works. Of course, that was a huge point of criticism. If you need such a skilled person to do that, it's really hard to scale that up in higher series manufacturing. And later on, this has been done on a really chip-based approach where everything was with electroplating, automatic contacting, and better. Receiver was on the 13.54 megahertz range. This is one of the frequencies you're allowed to use, and this is very important. If you design such a system, you should check up at the very first day before you do anything else which frequencies are allowed to be used. There's a sad story from a really cool application in the US where it happened that they unfortunately used an emergency frequency of the US Navy. And it took them 20 years to negotiate that frequency. In those days, the rest was already bankrupt. So they were not able to transfer that due to that frequency. You should take care that you don't use frequencies. That was another company. Don't use frequencies that are occasionally used, for example, when the New York Marathon or the Tour de France takes place, because then it could be so much traffic on that channel that it has higher priority than your medical data to the patient. So that all sounds very stupid, but it's a very important piece of work to check out. Is this frequency free? How strong are my competitors with respect to power? Is that short-term, long-term? If I can transmit on a short-term with high selectivity without getting coupling from the others, that's all fine. But if not, you have a problem. I love that picture for the sake of showing you that dimension here. That was one of the old chips, standard one, no thinned down. I mean, that's a nightmare, having a 500 micron thick electronic circuitry on a 10 micron thick foil. That's completely stupid. Nowadays you can thin that down to 30 microns, those chips, and then you have a really nice and shallow transition between electronics and supporting substrate. Stimulator could do up to 100 microamps and variable pulse width and a high repetition frequency to cover high spatio-temporal excitation of nerve cells. That was all, as you see here, purely technology development, a little bit separated from the biomedical application because it took a lot of groups, a lot of time, and so we shared the work, that some things have been done in vivo already, in animal experiments and others. There, this was here an electrode design, which was halfway clever, I have to say, and I'm allowed to say because it was my design. So we did a ring and a point. And this is good because if you have the ring versus the point, you have a very localized field. But doing it like I did, you need 2 layers of metal. If I just would have opened the ring a little bit, then it would still have been the point versus the ring, but I could have done that all in one metal layer, and technology would have been much easier. So this is something I learned afterwards, and others were more clever than I. They copied that concept and opened the ring and were much faster in process technology development. So that was the assembled implant. We were all very, very proud of that. And then we found out we forgot something. We have to insulate that before it gets implanted. Right? You cannot implant something with open contacts. You put them in salt water and you have short circuits everywhere. How to encapsulate that? And then it was first a Parylene C encapsulation, and afterwards a silicone rubber molding. And then it looked like that, the first version. A bit bulky, a bit very prototyping, but it should go into animal trials. And the question that was still open to those days was, if I stimulate the retina on 2 spots in a high resolution, do I really get 2 spots in the brain? And how is the assignment? So if I would have rho traveling from the left to the right, would I get a kind of rho activation from one piece to the other? And having that in mind, I came, okay, we should implant that, and then turned out, of course, there's no implantation method on that. It's brand new. Nobody has done that before, and so a lot of knowledge about eye surgery had to be combined. First of all, to get rid of the old lens in the eye, that's called a vitrectomy. Then, to get rid of the vitreous body of the eye, because that's very jelly and we have to implant that strip line and the stimulator, so get rid of that. That was phacoemulsification, that means to make that jelly part fluid, get it out, but replace it with another fluid, otherwise the eyeball would collapse. Implant the stimulator, and you can see here the transmission part, the strip line and the stimulator, and that is then pushed inside the eye somehow to align the receiver with the artificial lens, and to look through the receiver then on the back part of the eye, find your array and fix it. And we thought, well, if we do that, that took about 2 years, that development. Shouldn't we check in advance if we can stimulate? And then we thought, well, it could be good to have something with a cable on that. And that was the first version here with a cable on that went into an eye. And the idea was to prove that everything's work. We place that array on the retina and we stimulate. We check out if we elicit electrical activity on the optic nerve to be sure that there are traveling action potentials. And then we record on the surface of the brain if there's activity. And the guys we collaborated with in Bochum were persons who did intrinsic optical imaging. That's a technique which is still famous today, where you monitor the oxygen consumption in the brain by infrared light, and the rationale behind that is that you say if nerve cells are more active at that spot, they consume more oxygen because of their activity, and then you can monitor the oxygen consumption there by infrared light and get an idea how that looked like. And that was, that shows that setup, implantation in the eye, stimulation, recording on the optic nerve, recording on the cortex with intrinsic optical imaging. The blacker the picture is, the more active is the brain. That was here. The trial, so of course afterwards projected back on the image of the retina and shows how much current did we need for each and every electrode to elicit an action potential on the optical nerve. Showing that there are places where you needed nearly nothing and other places where you needed more. And this is a good sign how good the array is attached to the underlying retina. The closer it is, the less the stimulation amplitude you need for threshold excitation. And then recording from the brain, and again the pictures from the brain are projected then on the electrode array. And if you're a bit creative in interpretation of the pictures, you could say, well, the black blob is traveling from the left to the right, depending which stimulation contact I stimulate, and this is true for the different arrangements over the electrodes. That was the first proof of concept, or the idea that this thing could work. And the question was, would it also work if we do it wirelessly? And as engineers, we would say, of course, we don't care if it's wireless or not wireless, it's the same, but of course you have to prove that. And that was done in another study here, where this has been the chronic implantation. And if you look very carefully, you can see the electrode array here being placed on the back part of the eye. This is again an original picture in best possible resolution what the surgeon has seen. On the right hand side, focus on the transmitter. And in that study it came out for the first time that's feasible if you stimulate with a wireless system and such an array the retina, then you get spatial resolution over time in the cortex. And that promoted a lot of other groups and pushed them to do also work on those vision prostheses. For that study with one animal or two, it took us about 40 implants to manufacture just to get at least one or two at the very end who really worked. It was a huge group, just to acknowledge all the names and to show you how many persons worked on such a little piece of work for about 10 years to go there. And then it was really, and of course we got money for that from the German Research Ministry. But we were just at a prototype, and then others went on to transfer that in a device for human clinical trials. And a lot of things have been done in those days. There were 3 German companies. One was just set up for a human clinical trial, and afterwards they said, okay, now we proved that, and the market is that small, and we still need to do so many things, we stop here because there's no money to continue. And 2 others said, we really want to go, into humans, retina implant. That subretinal implant group had good luck. They found a person with a lot of money who was willing to invest over years, 3-digit numbers of millions of euros. They went up to CE mark device, so real medical product, did already a second generation of that. That lasted then for about 5 years and stopped in 2019 because they found out that the performance is such that it varies too much from patients, and there must be physiological background in that variation, and now this is bounced back to fundamental science. Also, the other company, Intelligent Medical Implants, they did some things which I don't know, but they were close to CE mark, and then they decided to move their headquarters from Germany to France for reasons I don't know. So they're still in the development. They have now a second concept which goes more to those photovoltaic cells to stimulate that you can get rid of cables. Yeah, this is a little bit a pity in that story. So a lot of companies, so it's a retinal implant, had the CE mark here in Germany, went into several patients, had in some patients extremely good results. So persons were able to read letters of 1 foot, so 30 centimeter size, even smaller, in real time, really fast. Others were able to discriminate between apple juice and Coke in a jar in a regular environment, could describe traffic, so really good things. But over the years, it showed that the quality of sight in those patients faded out, not due to the devices, but due to some physiological processes. And the same was true with the second sight thing in the US. They had implanted, I guess, 80 or 90 persons, and they stopped in 22, just in spring this year, since they do not see any longer a business model in there. And this is something we always should remember when it comes to those cool and crazy developments. That is sometimes really hard to predict if the business model is valid, that you can earn money with that, because you have to earn money, otherwise you cannot serve the patients. That is that trade-off. You have to earn money to run your company. If you can run your company, you can help patients with your products there. Yeah, so that means all those products are kind of bounced back to fundamental research. There are a lot of graduate schools, research labs that try now to understand how do we have to change the encoding of the stimulation that persons are able to better perceive the information, to better see, and which technological developments are necessary or mandatory to make it much better with respect to longevity and to stimulation selectivity. So a lot of things going on, so I think it was worth doing all that research, bringing things to the market, because otherwise nobody would have been able to recognize that it needs more developments to advance in that field. And that's sometimes a bit hard to admit, but I think it's important. Sometimes only the human being can describe if this is good enough for a human being. And with that, I'd like to close. I showed you several approaches with different ideas. They have been in clinical studies, many. A lot of developments have to be done with respect to encoding and to packaging to make them more reliable and give them a better performance. But it's still worth taking that example, how engineering and medicine can go hand in hand for completely novel therapeutic approaches. And I hope that in 10 years from now we will see something that is much better on a higher level where people can benefit from. Yeah, take-home messages. We have different manufacturing technologies that I've just mentioned site-wise. So photovoltaics, electronics, a bit precision mechanics, a lot of micromachining. Different anatomical sites need different design structures. And vision prostheses have shown that they can work at a certain extent, but unfortunately not good enough to become a real product on the long-term run. And if we like to draw something out of that for micro machines, micromachining, microelectromechanical systems, we see that flexible substrates are really preferable. Hybrid integration is good, but needs to be developed to a point where it's reliable and manufacturable. And long-term stability is still a major issue there. So we have to define what long-term is. Probably we can go up to 10 years. I'm pretty sure we cannot go yet up to 100 years, which would be a full human lifetime. With that, I'm at the end. Thank you very much. I'll try to stop it here.